ERCT.
Yes, क्या दिखता है, based on that we can see. So when did it come? Last time. लग रहा है तो सब चीज चालू कर 8 सेंटीमीटर की है इसको
जो कल वाली थी ना,
कौन बोल रहा है, कोई है कौन नहीं वो बुला बुला करूं मैं बुला ऐसे फोन गिरते हैं
अब मंगाई लो एक बार देख। हेलो, राजेश, ऐसा है कि मैं केस में हूँ, सर ने यहाँ बुलाया है, ठीक है, तो केस खत्म करके फिर निकलूंगा सर। लगेंगे, मुझे लगता है कि हो जाएगा आधे पौने घंटे के बीच में, ठीक है, ओके।
Okay.
वो देख रहा है जो अभी किया ना।
Mic is on, huh?
एक सोनी को बुलाइए, जो पेंटेक्स वाला सोनी है ना, उसको।
So maybe, I mean, looking at it, maybe, I don't know, huh? We have gone past. Yeah. So what is everybody's consensus?
It's interesting finding here.
Huh?
So I think this is your ampulla.
Yeah,
And
there's developed an ulcer here.
yeah, that's an ulcer.
That is making me suspicious. It is likely to be a cancer.
So yeah, I think
the way it's appearing, it's there's a lot of intraductal extension of the mass, and I think the EUS scope and passage has led to some mucosal trauma, but yes, there is the mucosal surface makes me concerned
What is
about.
the age of the
cancer.
patient? I mean, this ulcer makes me suspicious. It may not be a simple adenoma. Looks like a cancer here.
So, Dr. Saurav, which are the ampullary tumors which are eligible for ampullary adenoma? For ampullary resection, sorry.
So benign
Endoscopy.
adenomas, which don't have a great extension into the bile duct or pancreatic duct can be resected. Even sometime malignancy, if it is at the tip, and then the patient is very old and not eligible for surgery, then still it's worth an attempt to do a
Yeah,
and some of the neuroendocrine tumors.
So are there any size criteria or the extension criteria into the bile duct?
so I think you're answering.
You
Yeah.
can answer.
No, I think I think by and large, an adenocarcinoma of the ampulla is not considered an indication for ampulectomy, just to make it clear for all the audience. But the question really is, if there is a slight cancerous change in a by and large adenoma, whether you treat it the same as an adenocarcinoma of the ampulla or not. But my
Okay.
feeling is if you have extension into the muscle layer, then absolutely it is ruled out. Submucosa or muscle layer, I would say. But if there is nothing of that sort that seems concerning, and if you just purely see some change in the lining of the mucosa, a consideration can be made if there are comorbidities and the patient is old, giving the patient a chance that, that an endoscopic resection may remove it fully. But again, I just to make it clear, it's not a standard indication. As far as intrabiliary extension goes, I think the question is, how much of it is in the extraduodenal portion? Now, if you look at this mass, most of it is intraduodenal. So if you say this was not cancer and you're removing it, and you're removing the entire intraduodenal portion, probably the extraduodenal portion inside the bile duct, proximally outside the duodenum, is going to be limited, which can be removed with a snare. But again, I think whether this
So
is,
if this is the
cancer
only
change or
part, then we can remove it.
yeah,
It is going up to this.
right. It's probably even more proximal looking at the
Yeah, it
duct. Yeah,
is.
that definitely,
like-
yeah. That
up
looks
to
like the
this-
proximal
Up
extent.
to this place. This is,
Yeah.
there is no tumor here, but it is coming up to this and even here it is, I'm not able to compress this place. So
Yeah,
it is going up to this. So maybe it is not a good idea, ideal case for an ampulectomy. And patient is also quite not very old. He is
Right.
quite eligible for surgery. And he is deeply jaundiced. So maybe for a preoperative biliary drainage, we can do a ERCP in this patient.
right.
What
I
do you
think the
think?
surgeons may have their own opinions about the desire for biliary drainage and ampullary cancers.
So in our center, if the bilirubin is more than 15, we always drain it
Therapy,
before surgery.
including ampullary ones, not limited to pancreas.
Yeah.
Okay.
And there are other indication if patient has a cholangitis, we do a preoperative drainage. If surgery is delayed for some reason, for more than 3 months, we can do a preoperative biliary drainage. If they are unfit for surgery or if they require evaluation, they are hypoproteinemic, not fit for surgery for any other reason, or if they need a neoadjuvant therapy, then they need a preoperative biliary drainage.
Yeah, and
I think this tumor is too big for an ampulectomy. I
Yeah.
can see, you know.
I think it's
this,
the malignant transformation, which is almost
happened.
evident based on the appearance.
I mean, this is up to this place, there is it is firm here also,
Yeah.
so.
So do you think sometimes if you want to avoid the papilla knot and somebody doesn't know how to do EUS, I've seen them do choledochorionostomies with a needle knife up there,
Yeah, if we
which
make a
can
cut
be a
here,
simple option.
then.
It'll open up right
it'll
away,
open up,
make a cut.
uh,
Yeah.
So
And
you
you don't
want me
have
to
to.
do that or want me to try a ERCP?
So we'll let the audience decide what they want to see.
I think fistulotomy would be a better approach. It will shorten the procedure time also.
Huh?
Fistulotomy would be a better approach.
What is that?
Fistulotomy.
Yeah, so fistulotomy is a better approach. Yeah, I think it's
Fistulotomy,
a
then we'll
safer
do a
one.
Fistulotomy.
There is,
Okay, we will do a fistulotomy.
the audience here is also hoping for an ampulectomy.
They want.
Yeah.
If it, yeah, it's a
What
big
about-
tumor. I won't be able to completely remove it. And then if I do an ampulotomy, then I need to
Yeah.
do a pancreatic cannulation first and, you know, otherwise,
Yeah, I think ampulectomy is, again,
High
if this
risk
was
for
an
a
85-year-old
pancreas.
with a heart failure of 20% ejection fraction would be a consideration
what is
again.
the age of the patient? 80 years? What is the age of the patient?
60s.
So then he will be an eligible candidate for surgery.
Mhm.
And if I cause a pancreatitis, the problem is then their surgery will be postponed for at least 2-3 months. And by the time he might become ineligible for surgery or may develop a life-threatening complication. He's quite young. And this tumor, all of us believe, can be resected for cure by ampulectomy. So it should be curable by surgery. So I don't want to produce a complication which will make him ineligible for surgery. So we are going to do a fistulotomy. So what we'll do, I mean, there is a small spontaneous fistula or an ulceration where I mean, it is not bile. Patient is jaundiced. Even serum will appear yellowish, and we shouldn't be tempted to think there is a
Mhm.
bile. So I'm going to do a fistulotomy only.
Okay.
Okay, needle out.
So this is for the audience, this is a non-EUS choledochorionostomy.
So let's see. Needle out. Where is?
I expect a free flow of bile to come. And Dr. Ravi, yeah, there you go.
What do we do now?
Yeah.
It is open already. Bile has started coming. So
Right.
do we put a stent? We leave it like that, or make a little more incision with the sphincterotome? So Malay Sharma has given me
Yeah.
only 5
I think
minutes to do this procedure.
I think placing a stent I'm not sure if it'll be of benefit to the surgeons. They can probably opine if there's someone in the audience.
So we can leave
But I
it.
do like
What
to
does- is
have a
there any
stent.
surgeons, there, I think this opening is much bigger than the ampullary opening. So
Yeah.
even without a stent, it will drain well.
Yeah, I think it'll
So we
decompress
can-
quite well.
Yeah, quite well. I think maybe we will make this opening slightly bigger. And this is a sphincterotome. So I will cannula. Gone?
Can we have fluoroscopy images, please? So,
It is not going. It's gone.
oh,
So
nice.
what I will do, I mean, I'll make this opening slightly bigger. And you want fluoroscopy? And it will be inside the bile duct only. And then we won't leave a stent there.
Do you foresee any risk of cholangitis if this patient has a delayed surgery and if this opening closes down?
This is much above the tumor.
Yeah,
If the surgery is postponed indefinitely, then it might close. But leaving a metal stent in this won't help because
How about
metal stent will migrate quite.
yeah, no,
easily.
just a 10 French or 7 French plastic stent to keep it
Um,
intact and open until the
This
surgery.
opening is so big, I think we can leave it like that. I think
Okay.
there is a pus coming also. So there is a clear indication. You can see purulent material coming.
Mm-hmm.
So you see some, it is
Yeah.
not clear. So yes, a cholangitis. What do you want me to do, Mala? Should I do a stenting?
Is it an ampuloma, not an ampuloma?
I
It's a
think it is.
malignancy. It
malignancy.
appears like a malignant
a-
transformation
there
of
is
an adenoma, maybe.
Also here, this is quite unusual for an adenoma. This, I can do a biopsy from here. It looks like a
Yeah.
malignancy.
Quickly place it. You did a pre-cut from above?
Above
Fistulotomy.
and.
Okay, that is a good thing.
So
So that was a good fistulotomy.
slightly
and-
drain and it may not require a stenting. And anyway, he will be undergoing a surgery sooner. This looks like a tumor.
Yeah,
This
okay. So we
vascular
will shift
pattern.
Ravi.
Yeah.
To the other room.
I will take a few biopsies and close.
Okay, okay.
Thank you.
Nikita Bahar. No, you have to stand out. We don't want too many people.
Uh, They can, but
History. someone- Okay,
if we produce a pancreatitis,
in.
then disaster. Generally, I have done few, but generally two, 3 times if
off,
I do a biopsy, see, 2 times it comes as negative. No, if it comes, then you can think about close.
Woodle hypertension में थोड़ा सा, लेकिन देख लो।
बस एक लक्षण दिखाई दी ना मेरी।
And that is the commonest thing at this age also.